COVID-19. The briefing is being carried live on YouTube. Joining us for today's briefing are DHS Secretary-Designee Karen Timberlake, Dr. Ryan Westergaard, the Chief Medical Officer in the DHS Bureau of Communicable Diseases, and Dr. Ashok Rai, the President and CEO of Prevea Health. And we'll begin with remarks from Secretary-Designee Karen Timberlake.
Good afternoon, and thank you for joining us. For nearly 2 years, we have been committed to keeping you well informed about the ever-changing landscape of the COVID-19 pandemic so that you can make safe decisions about your own health and the health of your families and communities. With the winter holiday season upon us, I want to be sure to paint a thorough picture of the realities we are facing in Wisconsin. First, I'm sad to report that since the beginning of the pandemic, we have lost more than 9,000 Wisconsinites to COVID-19. This is a milestone no one ever wanted to see, and our sympathies go out to those who have lost loved ones to this disease. I know that we all hoped we would not find ourselves in this situation again, but we are adding thousands of new confirmed cases each day. These are numbers we haven't seen since last December. With the new concerns posed by the Omicron variant, it is important that we all come together now and do whatever we each can do as individuals to keep ourselves safe from COVID-19 and avoid spreading this disease any further. Here's what we know about this new variant. In the 6 days since the World Health Organization first identified it as a variant of concern, the Omicron variant has been identified in at least 24 countries, including here in the United States. Early data from South Africa suggests that the Omicron variant can be spread more easily than prior versions of SARS-CoV-2, including more easily than the Delta variant that we've been dealing with for the past 4 months in Wisconsin and around the country. With that said, Omicron is still a variant of SARS-CoV-2, the virus that causes COVID-19. And as of today, Delta remains the dominant variant in Wisconsin, as in the US, and is found in more than 99% of the virus samples that our lab partners evaluate. Based on what we know today, as with previous strains of this virus, we have tools in our toolbox that can help slow the spread. The COVID-19 vaccine provides the best protection against serious illness, hospitalization, and death. That's why we urge everyone ages 5 and up who is not vaccinated to get the COVID-19 vaccine. If you are 18 or older, and it has been at least 6 months since your second dose of the Pfizer or Moderna vaccines, or at least 2 months since you received the Johnson & Johnson vaccine, we encourage you to get your booster shot. Go to vaccines.gov or call 211 to find your vaccine. Wisconsin continues to be a leader in vaccination efforts. Over 87,000 children ages 5 to 11 have already received at least 1 dose of the COVID-19 vaccine. This week, we also topped 1 million booster and additional doses administered. We want to thank all of you who have stepped up and helped the 5 to 11-year-olds in your lives get vaccinated, as well as all of you who have already gotten your booster doses. And we want to say a special and a big thank you to the vaccinators across the state whose work has made this all possible. In addition to vaccination, wearing a mask when you are in public indoor settings, staying home when you're sick, avoiding large gatherings, maintaining good hand hygiene, and getting tested if you're experiencing symptoms are all important steps we can all take to slow the spread of COVID-19. We need to buckle down and commit to taking these steps. We all have responsibility for keeping ourselves and our family members healthy so that our kids can stay in school, workers can be at work, and our hospitals and nursing homes can care for the people who really need them. Because of our continuing high case rates, COVID-19 is continuing to stretch our hospital capacity. If you aren't vaccinated against COVID-19, your chances of ending up in the hospital are 9 times higher than someone who is fully vaccinated. If you are age 50 or older, that chance goes up to 13 times. And even if you are under 20, we've had more than 1,800 young people in the hospital with COVID-19 since March of 2020. Statewide, 97% of intensive care beds and 98% of intermediate care beds in our hospitals are currently in use. With so many hospitals and healthcare workers already stressed by caring for COVID-19 patients, it becomes increasingly difficult to treat patients who need to come in for other reasons. We want you to seek medical care when you need it, so please do your part by getting vaccinated against COVID-19 and the flu so that we can protect our healthcare workers and preserve space in our hospitals for our friends, neighbors, loved ones, and even ourselves. Together with Governor Evers, all of us at DHS remain committed to supporting our healthcare systems in whatever ways we can. Together with Wisconsin's hospitals, we have implemented robust surveillance systems to gather real-time information on hospital capacity to inform our response strategies. We are currently providing staffing support to assist hospitals, nursing homes, and assisted living facilities across Wisconsin in meeting the needs of their patients and residents. We are ensuring equitable access to monoclonal antibodies for the treatment of COVID-19, which have been shown to prevent severe disease and reduce hospitalizations, and we will do the same as new therapeutics become available. I'd now like to turn it over to Dr. Rye to say a few more words about how our health systems are doing right now. Thank you very much for being with us today, Dr. Rye.
Thank you, Secretary Timberlake. And, it's an honor to be here, and wish I was here for better reasons, but unfortunately, our healthcare systems are overwhelmed right now. I did a little math yesterday, and just looking at our own hospital beds, almost 20%, in some cases more, are being occupied by either somebody who's actively being treated for COVID-19 or has now left their isolation phase, but still is in the hospital because of long-term effects. Our hospital systems, no healthcare system is designed to have 20% of extra capacity just sitting there waiting for something. This is usually the busiest time of year for us in healthcare as we enter the winter months, especially living in Wisconsin, where we'll see traumatic accidents, we'll see an increase in heart attacks and strokes and other illnesses. And even recently, on a single day here in Green Bay, one of our hospitals had to say no to 28 patients being transferred in that needed them, including 3 strokes. And those families unfortunately had to have their family members transferred over to 100 to 200 miles away just to get basic care that they needed. This wouldn't happen if we had those beds and the staff available to take care of them, which are now being occupied by COVID patients. It's important to understand there may be an empty bed as you walk down a hospital hallway, but a bed is not a bed in healthcare. A bed is a room, nurses, CNAs, our EVS staff that clean the room, and physicians to take care of that patient. And COVID-19 patients are extremely labor intensive. So one COVID patient may take away up to 3 beds for a different type of disease. So that 20% is becoming much more exponential for us, and we need your help. We need to make sure our hospitals are there to take care of everybody, and that care can stay local. Thank you.
Thank you. And we'll now take your questions. To ensure audio quality, please stay on mute until it is time to ask your question. And remember, *6 will mute and unmute your phone. In the interest of time and to make sure everyone gets a chance to ask a question, please only one question per reporter. And we'll begin this afternoon with Scott Bauer from the Associated Press. Scott?
Hi, thanks for doing this call. For whoever wants to field it, I assume since nothing's been announced, we don't have anyone confirmed with the Omicron variant yet here in Wisconsin. And assuming that's the case, is it also safe to assume that it likely is here, given the level of testing that's going on and given what we've seen elsewhere around the country and around the world in terms of it popping up?
Sure, thanks, Scott. Dr. Westergaard, maybe I could suggest that you take that question and just say a few words about how we sequence positive samples and how we are likely to find the Omicron variant when it arrives.
Sure, I'd be happy to. So we've not confirmed any cases of the Omicron variant in any patients in Wisconsin, but we are actively testing specimens that have tested positive on PCR using whole genome sequencing to detect what variant they are. And as Secretary Timberlake indicated, it's virtually 100% the Delta variant. There's a bit of a lag from when a patient gets tested and when the sequencing results are available, sometimes 1 or 2 weeks. So it is, to your question, possible, perhaps likely, that the Omicron variant is circulating more widely in the United States, and it'll take some time for us to detect it, and we'll report that when we do. The resources that we have to look deliberately or extra hard for the Omicron variant is a lot of relationships that we've developed with clinical laboratories and providers who can be aware of patients who have perhaps a travel history or anything unusual characteristic about their case, and they can get specimens sequenced upon request at our state lab or one of our laboratory partners. So we've developed a lot of infrastructure to do this, and we are searching actively, and we'll continue our surveillance activities and report with our laboratory partners.
And just to add on, this is why it is important that people continue to get tested if they know they've been exposed to someone with COVID-19, if they're experiencing COVID-19 symptoms. It is through this testing, as Dr. Westergaard just alluded to, that we will identify cases of this new variant and, of course, potentially other variants.
Thank you. Now to Victor Jacobo from CBS 58 in Milwaukee. Victor?
Hello, good afternoon. Thank you for taking the call. The Biden administration today announced an effort to make at-home tests free. I was wondering if you could kind of speak about, any guidance for folks as we do enter the winter months about at-home testing, the effectiveness of them, whether there's preferred to go to a pharmacy or if preferred to use a at-home test if available. Thank you.
Yeah, I'll start again on this one, and then happy to have Dr. Westergaard and Dr. Rai add their points of view as well. So first of all, the president's new plan obviously just is coming out today. We will take a good hard look at it. Very pleased to see efforts to make sure that at-home testing and other forms of rapid testing will be made covered by insurance, and thereby making them lower cost and more available for people. And I think in terms of kind of the utility of those tests as compared to the other forms of testing that are available, happy to have the physicians on the call speak to that.
Yeah, I would add that at-home testing can be a useful resource when added to our mix of other testing resources. But it's clear, and the important message is that we need to have a variety of opportunities and options for people to get tested. The benefit of being tested in a public health or a healthcare setting is that results are highly reliable based on in the laboratory, and also then we have the results immediately imported to our public health databases, and specimens can be made available for sequencing. At-home tests can provide a rapid result when it's needed, and sometimes that's necessary. So I would look at this as a useful addition that can be helpful in some circumstances, but not a replacement. And we certainly encourage everyone to make use of the testing resources that we have in communities and health system associated laboratories and public health departments.
Thank you. Now to Sarah Seifert from the Eau Claire Leader Telegram. Sarah?
Hi, thank you for taking my question. Considering that COVID cases have been elevated for several months now in Wisconsin, can you give us an idea of what you're hearing from hospitals and healthcare workers? Specifically, are hospitals in a better or worse position than they were at the same time last winter? Thank you.
Sure, let me offer maybe one statistic to shed some light on this, and then Dr. Rai, that would be a great perspective for you to offer as well. So one thing we do know is that just a couple of days ago on November 30th, we logged the highest number of patients we have had yet in the state of Wisconsin who have needed to rely on ventilation in order to breathe. due to being infected and in the hospital with COVID. So that was 688 patients on November 30th. And the previous high was 638 on November 18th of 2020, so a full year ago. I know that we're also hearing from hospital partners that due to the Delta variant, patients are typically a bit sicker as they are coming into the hospital. They are also younger than last year's hospitalizations tended to be on average, in part because we have done such an amazing job of vaccinating so many older adults, thereby protecting them and keeping them out of the hospital as much as we can. And they are staying in the hospital longer. And all of that contributes to the pressures that Dr. Rai was speaking to earlier. But Dr. Rai, I'll pass it to you for some other insights.
Well, thank you. And I think you covered the high points there mainly. You know, it's a different version of COVID-19 this November, December than it was last year. Delta definitely acts differently. Our patient population is different. Our most vulnerable are protected, which means that the majority of what we're seeing in the hospital are completely unprotected and unvaccinated individuals who get very, very sick. And once again, that's compounding on every other illness that we're seeing. So hospitals are under great pressure, staff are under great pressure. This has been a long battle for those of us in healthcare, especially our frontline nurses and in the ICU. So it has been exhausting, and you know, it has created a sense of, at times, a little bit of frustration with when are we going to be able to move past this, and it's not now. And it's very frustrating when you know you have a stroke patient coming in and you can't take care of them the way you want to, because basically an admission that's preventable through vaccination is happening. So I think from a hospital perspective, we are overwhelmed. It's a different kind of battle this year than last year, but we will continue to fight the fight.
Thank you. Now to Drake Bentley from the Milwaukee Journal Sentinel. Drake?
Hi, thanks for doing this call. I get emails from readers about vaccination status of those that are hospitalized or passed away. Wondering if there's any data on vaccination status for those that are in the hospital or died.
Sure. One way to look at this would be every month now, on the 15th of the month, the Department of Health Services is updating our data based on what we know about people who have ended up in the hospital with COVID or have passed away due to COVID-19, and those who have been vaccinated versus unvaccinated. What we know in the aggregate is that on average, people who are unvaccinated are 9 times more likely to be hospitalized than are people who have been vaccinated. And I believe the latest data is that people who are unvaccinated are dying at a rate that is 11 times greater than people who have been vaccinated. Dr. Westergaard or Dr. Rai may have other ways to shed light on those data, but the bottom line is that vaccines are highly protective against hospitalization, serious illness, and death from COVID-19.
I'd say from just boots on the ground right now, you will get vaccinated individuals that wind up in your hospital. Some are actually there for COVID. Some we find out they have COVID-19 because they're for a different reason, say an appendectomy. But they still get counted because they still have to be isolated and treated like a COVID patient, and their outcomes could be worse because of that. But the majority of what's overwhelming us right now, the vast majority of the intubated patients, the ICU patients, are the unvaccinated. We know statistically that they're going to be sicker despite the therapeutics we have available to us today. They are the ones that are not only using the highest amount of resources, but staying the longest.
Thank you. Now to Kyle Ives from NBC 26 in Green Bay. Kyle? And a reminder, *6 unmutes your microphone. Kyle Ives from NBC 26. Okay, we have to move on then to Logan Rood from WISC TV News 3 Now in Madison. Logan? News 3. Moving on then to Will Cushman from PBS Wisconsin. Will?
Hi there. Thank you. I am curious about the potential impact of influenza this winter. We know that influenza is already beginning to circulate in Wisconsin, and hospitals and healthcare workers did not really have to contend with flu patients last year while treating COVID patients. I'm just curious to get the perspectives of Dr. Westergaard and/or Dr. Rye about planning for an influx of flu patients in addition to COVID patients, and/or just kind of how you're feeling about the winter respiratory illness season this year. Thank you.
I'm happy to go first. Thanks for that question. We don't know what to expect with this influenza season. But there are reasons both for concern and also potentially for optimism. We know from last year that when we do use prevention strategies like masking and social distancing, that we can cut down the rate of all respiratory viruses. And we essentially saw no influenza circulating last year. So that gives us some hope that we can use non-pharmaceutical interventions to prevent flu from becoming widespread by doing things that we already know how to do. Now, the concerning news or the bad news is that we're already seeing more flu this year than we did last year. So we're not going to have a zero flu season, but we have learned that we can control it. We've seen some outbreaks among younger people. There's been some college campuses in the Midwest. We released a health alert network to make people aware of that fact that flu is now circulating at low levels. And the important thing is that, and the other reason for concern is that we are a little bit behind our usual pace in influenza vaccine compared to last year and traditionally. So I think we haven't been paying enough attention collectively on encouraging influenza vaccination during the second year of the COVID pandemic, but it's very, very important because as Dr. Rye said, there's not a lot of extra capacity to go around. In a typical flu season, if we have many flu cases, that's going to translate to many people in the hospitals, and we really can't afford that. So the two things that we can do is everyone get their influenza vaccine and then use the prevention strategies that we know prevent COVID and other respiratory viruses to really avoid this additional strain that could come from having a lot of influenza circulate.
Thank you. Now to Denise Lockwood from Racine County I. Denise?
Hi. Thanks for taking my call. My question is around staffing and the impact of the vaccine mandates where hospitals are requiring staff to be vaccinated. I'm hearing locally that one hospital has lost about 50% of staffing, but that's an unconfirmed number. And this has resulted in a significant number of beds being kind of taken out of the availability. So I'm wondering how statewide we're doing with that and how the state plans to address that issue.
So, yep, happy to start with that. And then certainly Dr. Rye can give a firsthand perspective. So we certainly have not heard reports of that level of staff departure from any of our health systems that have adopted a vaccine requirement, and the overwhelming majority, if not all of them, have at this point, for which we are very appreciative. We know that requirements and those kinds of policies do work to encourage vaccination, and we know that vaccination is the most effective way that we can prevent the spread of COVID-19. If you can imagine yourself as an immunocompromised patient coming into a healthcare setting for necessary treatment, you will want the care team that is taking care of you to be well protected against an illness that could make you very sick or potentially kill you. So vaccines remain extremely important. As far as what the state is doing to support hospitals, skilled nursing facilities, other kinds of long-term care providers, we have, as we have in the past, engaged some staffing contracts to help with sourcing staff from other parts of the state, other parts of the country, to bring those staff here to Wisconsin to fill in the gaps that may exist for whatever set of reasons for those kinds of critical care providers. The thing that's important for everyone to understand, and the reason we are focusing somewhat on healthcare capacity today, is that that pool of staff is limited. COVID, as we know, is continuing to be a concern and is continuing to tax healthcare capacity and long-term care capacity, not just in Wisconsin, but in Minnesota, in Illinois, in Iowa, in every state in the country. And so every state is, in some sense, competing for that same set of very limited resource, in this case, staff who are qualified to do the work that needs to be done in all the care settings that we've been talking about. So that is why it is so important for all of us to take every step that we can take to prevent the next case of COVID-19, because preventing that next case of COVID-19 protects that next increment of hospital capacity, nursing home capacity that we know we need to meet the needs of our state. But Dr. Rai, how has this looked for you at Prevea?
Yeah, it's definitely not been 50% of our staff. It actually was a handful of our staff that we lost, due to our vaccine requirement, which was done, with very careful consideration for religious exemptions and medical exemptions, but still with the thought process of protecting our community, protecting our patients, and keeping our infrastructure solid and going. In other words, keeping our healthcare workers healthy so we can continue to take care of those who are sick. So even within our region and talking to colleagues, it's truly been a handful. It's also important to remember, and we are in the state of Wisconsin lucky to say that, as the secretary pointed out, that the majority of healthcare organizations do have such a mandate in place. So it's not like you have 50% of staff leaving one organization and joining another. It's been pretty consistent throughout that we've had that, and we continue to appreciate the help from the state to help us with our staffing issues. But more of the staffing issues are, like I said, nobody's quite prepared for another 20% on top of what you're used to taking care of, overwhelming your ICUs before we've even seen, significant influenza cases in the hospital. We're starting to see them in the community, but not in the hospital. So really the stress isn't a lack of physical space. We're normally staffed. It's getting that extra 20% of staff that's really stressing us. So yes, the mandate may have caused a handful of people to leave our organization, but that's not what's creating the issue at hand.
Thank you. Now to Adam Rogan from the Journal-Times in Racine. Adam? Adam Rogan from the Journal-Times. Okay, we'll move on then to Brittany Slaughter from WAOW-TV in Wausau. Brittany. And a reminder, *6 unmutes your phone. Brittany Slaughter.
Can you guys hear me? This is Adam from the Journal-Times.
We can now. We'll take Adam first, then. Adam,
there we go.
Ahead.
Somebody said earlier that the Omicron variant appears to be more transferable and contagious than the Delta variant. Is it believed to be any more deadly or cause any more illness?
I can take that one. So what we've observed so far is how fast the Omicron variant spreads through a community. And that was what got everyone's attention in the South African region, where it showed up very quickly and then became the dominant strain of the virus that was circulating. So we've kind of answered that question, that it spreads very efficiently and very rapidly. We do not have the answer to the question of, does it cause more severe disease? That's something that a lot of scientists are looking at very closely. There's been some anecdotes of the initial cases having not very severe illness and generally being mild. but I don't think we can count on that being true for the general population. There's been too few cases to really characterize the full spectrum of clinical illness. So we should presume that it is another variant of SARS-CoV-2, which can cause severe disease, and do all we can to stop it from spreading. But some of those really important questions that have been raised about whether vaccines and therapeutics, that monoclonal antibodies will be as effective at this variant, are really unknown, but being actively investigated right now.
Thank you. Now to Megan Kernan from WBAY TV in Green Bay. Megan? WBAY?
Hi, thank you for taking my question. I was curious, as state numbers increase and as we see more Omicron cases in the state, will there be more testing clinics being opened throughout the state?
Sure. So a couple of ways to think about that. First, I think it's really important to note that the primary variant of concern remains the Delta variant. That is what is spreading everywhere across our state right now and across the country. We do have very robust testing networks all throughout really every county, some in partnership with local public health departments, some in partnership with health systems. We have a lot of employers that contact us to help with testing as needed. We have a very robust testing program going on in our K-12 school system. We have, I believe it's nearly 75% of the public school districts in our state participating with us. Just in the month of November, data almost all in, we tested more than 35,000 kids in our schools, kids and staff, to make sure that we can catch COVID early and keep our kids in school. So as the need to create more testing capacity may present itself, we will be there ready to help. We have had great partnerships with the Wisconsin National Guard, which continues to work with us to stand up some testing capacity where communities contact us and let us know that that would be helpful. So lots and lots of options. What I think is important for people to know is that both on the Department of Health Services website, it's easy to find information about where to get a COVID test, particularly one of those laboratory confirmed tests, a PCR test that Dr. Westergaard was talking about earlier. In addition, in nearly every pharmacy in our state, particularly chain pharmacies, but even quite a number of independent pharmacies, COVID-19 testing is also available, sometimes by appointment, sometimes on a walk-in basis. So really strongly encourage people who know that they've been exposed to COVID-19 or are feeling symptomatic and feel that a test would be a good idea to check into those resources and do get yourself tested.
Thank you. Now to Alex Moe from WISbusiness.com. Alex?
Hi, thanks for taking my call. You mentioned the Omicron variant may be more transmissible or infectious, and because of that, will the state's public health efforts and measures have to change or adjust to prepare for the presence of that variant here in Wisconsin? Thanks.
Right, it's a great question, and I think I would put it on the list of Dr. Westergaard's questions, to which we know the question is out there, but we don't know the answer yet. It is just simply too soon to know what this variant will bring. What I think we can say is that we have the tools available today to control and stop the spread of COVID-19, and we are seeing that that is happening effectively in some places and not so effectively other places. So I think really leaning into vaccination, wearing a mask when you're in a public indoor setting, getting tested if you feel symptomatic, staying home when you're sick, all of those things are the right thing to do to combat the Delta variant. And as far as any of us know right now, they will all be the right things to do if and when the Omicron variant does start to circulate more widely.
Thank you. Now to Eric Gunn from Wisconsin Examiner. Eric?
Hi, thank you for doing this call. The later data that has been coming out has shown that kids, infection among kids has been, anywhere from younger to 18, has been a larger proportion, as I understand it, of new cases. I guess what's the big picture demographically? Is this becoming more a disease of children, or is that number simply an artifact because of the lower vaccination rates of children? How is that sort of changing the patterns of the disease? Thank you.
Yep, great questions. I'm happy to start and welcome colleagues to hop in here. So you are noticing the right trend. So from the end of August through now, so through end of November, early December, young people under the age of 18 have gone from having the lowest number of cases, lowest rate of COVID infection, to actually having the largest number of cases. And we have data on the DHS website that really shows you that dramatic change over just a few short months. We also know that within that younger age group, it really is kids between the ages of 4 and 13, 4 and 13, who are showing the most significant growth in cases. So the very, very young children, 0 to 3, tend not to show quite as many cases, and older teens who we know were able to be vaccinated starting earlier in the year also don't have quite the same rate of or number of new cases. So what that tells us is that certainly vaccination is protective, because again, older teens and adults on up the age spectrum who have been vaccinated have been showing a greater degree of protection against COVID infection. The good news with kids is that now kids ages 5 to 11 can be vaccinated. And as noted, we've had more than 87,000 kids in that age group get their first shot just in the last couple of weeks. So that is a very encouraging trend. We are eager to see that start to bend this new case curve, both because it's important for those kids to be able to stay in school, continue with activities that we know they want to participate in. Also because even though children don't get as sick typically as older people do with COVID-19, nevertheless, as I noted, we have had 1,800 young people in the hospital with COVID-19, and I cannot think of a scarier circumstance as a parent than to be managing something like that. And finally, we know that kids live in families. And so a child who is infected with COVID-19 is very likely to transmit that infection to a family member, a loved one, a relative, and all of that contributes to the problem that we're all working so hard to combat.
Thank you. Now to Sean Kirkby from Wisconsin Health News. Sean.
Hi, thanks for holding this. Just was wondering, for the DHS staffing contracts, how widely are those being utilized in the state? Like how many facilities are using them and how many staff are there? And how are you kind of deciding which facilities get the staff? Thank you.
Yep, you bet. Happy to follow up, Sean, on some of the sort of finer points of the numbers, but on balance, there are some criteria that the requesting facilities do need to meet, in part because there are federal resources being used to reimburse the part of the cost of these contracts. And so those resources do come with some criteria and some requirements. We have an application process that hospitals, nursing homes, assisted living facilities can fill out. And then from there, it's a matter of kind of matchmaking between the facility and one of a number of staffing vendors that the state has engaged to help meet some of these needs. Again, as I noted before, this is really an important resource, something that we're happy to make available, and it is limited. The numbers of people who are available to us, whether that's nurses or CNAs or respiratory care therapists, the kinds of people who really are needed right now in the COVID-19 response are needed absolutely everywhere. And so we're continuing to problem solve and troubleshoot with our health system and long-term care partners to the greatest extent that we can, but it is a challenge.
Thank you. Our next question belongs to Shemaine Mills from Wisconsin Public Radio. Shemaine?
Hi, thanks for the call. I'm hoping someone can explain why more people are being put on ventilators earlier. We heard that if they were flipped on their stomach or they had antivirals, there were a number of ways to avoid using a ventilator. And so why are we seeing more ventilator use now?
I'm happy to answer that. You know, what we have seen is definitely a change in the virus. As we mentioned, the other mutations we've seen, but the Delta variant has definitely created a sicker patient for us. Obviously, it's our last option to put somebody on a ventilator. We still do prone patients, as you refer to them as flipping them. We do put them on their belly, and it does help. But and we actually have new therapeutics that we use too, medications we use. But given the nature of the virus as it is today, and the unvaccinated patient especially, and how sick they present, they have much higher likelihood of going on the ventilator, and that's what we're seeing with Delta. And that was shown internationally and definitely shown here in the United States.
Thank you. Now to David Wahlberg from the Wisconsin State Journal. David?
Yeah, thank you. Dr. Rai, I know hospital leaders have talked about nursing home capacity affecting hospital capacity. I'm wondering, among the COVID patients in your hospitals or in hospitals generally in the state, do you know sort of roughly what percentage still actually need to be there versus what percentage are waiting for nursing home beds or to be transferred elsewhere?
You know, I don't have a percentage today, but there's no doubt, and I primarily actually work in a nursing home, you know, to receive patients like that has created some of our issues. So if a nursing home has a COVID outbreak, or they have to close down a wing, or their staff have COVID, that creates a backlog in the hospital. And then once again, COVID in itself is creating issues in the healthcare system, not only in somebody in the ICU, but, you know, waiting to get that patient discharged. There are times where we may have up to 14 patients waiting, you know, that are occupying a bed, waiting for a nursing home bed, but there's no nursing home capacity because of the same issues. We may not have capacity due to COVID coming through. So it's a definite issue. It's one that the state has worked with us on solving, as the secretary mentioned, getting more staffing, not only in the hospitals, but into our long-term care, so more patients can move through the system. But it all really is due to COVID at one point in that healthcare chain.
The thing I would add to that, and thanks, Dr. Rai, is one of the things that has been true throughout the course of the pandemic is that we really have worked hard to relax as many regulatory limits as we can do safely, to make sure that we can have staff available to care for patients, just as your question suggests, and as Dr. Rai was alluding to. And one example of that is that we continue to maintain in this state a rapid certified nursing assistant training program that many of our skilled nursing partners are taking advantage of, so that we can train people to be certified nursing assistants, provide kind of that basic level of support in a skilled nursing setting, and get them on the job and working as fast as possible, while then continuing their full education and getting them to a point where they're eligible to be on the CNA registry and really be qualified to work as a CNA anywhere. So that is just one example of a number of strategies that we have deployed and will continue to deploy to make sure that we have absolutely everybody available to provide this important care.
Thank you. Now to Kent Wayne Scott from WISN TV in Milwaukee. Kent?
Hi, thank you. Good afternoon. With hospitals stretched to their limits already and a new variant and the holidays approaching, do you anticipate the need, and at what point might you consider setting up an auxiliary hospital, such as the type we saw, for example, at State Fair Park last year?
Right, great question. You know, what we are working hard to do with our hospital partners and with our skilled nursing partners is to avoid needing to set up a separate or auxiliary, as you're describing it, care facility. As Dr. Rai really described, the kind of brick and mortar capacity is actually not the problem. We have space for people. What we need to make sure that we can do is have adequate staffing all along that entire continuum of care, so that patients who don't need to be in hospitals any longer can be discharged to post-acute settings, so that people can be managed in outpatient settings and not need to end up in hospitals. And of course, preventing as many cases of COVID and as many cases of the flu as we possibly can. So I think what you're seeing in this state and around the country is those alternate care kinds of settings were the right strategy at a point in time, as the disease has continued to evolve and change, and as our knowledge about both how to manage it, but also how to prevent it has continued to evolve and change. Our strategies are evolving along with it.
Thank you. Now to Madeline O'Neill from Fox 6 in Milwaukee. Madeline?
Hi. Hi, thank you. So you've answered most of my questions, but one thing I would like to ask, more talking about the Omicron variant and how you're looking to see if there's any potential for it to be more severe. I guess I'm asking, since we know with the mutations that, it gives it higher potential to be more transmissible. Do we think it gives it higher potential to be more severe, and kind of what is the timeline on figuring that out, looking in real situations?
Yeah, so it's very difficult to predict how the virus behaves in the body when it causes an illness, just based on the mutations. We've seen some of the mutations that have showed up in the Omicron variant in other variants of concern. Others are brand new, and we've never seen this specific combination of mutations. So it really is a new entity that we need to learn about. There's been some prediction about whether therapies like monoclonal antibodies or vaccines will have the same effect or the same binding because of the changing of the shape of the virus proteins. We're hearing mixed concerns about whether that will be an issue. In terms of how long it will take to understand the question of does it cause more severe disease, that's something that we can't do experiments on. We just need to observe. And so I think in the coming weeks, probably within the next month, we will be able to observe enough people who have gotten sick with this variant around the world to see and compare, based on adjusting for age and other medical conditions, whether it seems to be causing more severe disease. It's a difficult thing to study. And with the Alpha variant in the United Kingdom, there was actually conflicting reports. So it's not clear that the existing variants of concern seem to not have substantially increased virulence or more severe disease. This one, we have to use those same methods, and it'll take some time to know for sure.
Thank you. Now to Rhonda Fox from WKOW-TV in Madison. Rhonda?
Yes. So we have a vaccine and a booster, and COVID numbers in Wisconsin are pretty close to last year. On November 30th, we had about 4,200 cases, and this year we have about 4,500 cases. And with the new variant, how do we get COVID numbers to drop? And if you could kind of respond in light of Biden's newly unveiled winter plan to combat the coronavirus. Thank you.
Sure. As noted before, that plan is brand new, and so happy to touch on a few highlights of it, but we will obviously be studying it further and lining up our strategies with the president's plan. I think what among the things that has really changed from last fall to this fall is the arrival of the Delta variant. So what we saw, if you think about sort of between November and July-ish of this year, we did see a really steady decline in cases, and that was with the advent of vaccines and before the arrival of the Delta variant. And the reality of it is Delta is just that much more contagious. And because we had, some groups of people are 65 and older who were highly, highly vaccinated, but other groups of people, younger adults, and as noted, children who were not vaccinated to nearly the same degree, or in the case of kids, not at all, Delta found lots of people that it could infect. And so that really is the situation that we are continuing to deal with. I'm glad you mentioned boosters. That obviously is a key feature of the president's plan, and really promoting boosters, particularly for older adults. We're not quite where I think we would hope to be as a country, and making sure that our older adults who are most vulnerable to COVID-19 get their booster dose. And so really it's important for people who are 18 and up, more than 6 months past their second dose of Pfizer or Moderna, more than 2 months past their Johnson & Johnson shot, to go get that booster dose. The president's plan also, touches on testing, touches on other strategies in the workplace to help keep people safe, including making sure that employers are giving people time off to get themselves vaccinated, to get their children vaccinated, and maybe to take a sick day should they experience side effects from a vaccine. And that's really worth emphasizing, that there are things the employer community across our state has been doing, and we encourage more employers to continue to do, to make sure that we make it as easy as possible for employees to get vaccinated, whether that's bringing a vaccine clinic on site, giving people a day off, but also thinking about employees as parents who have children who are now eligible to be vaccinated, and sometimes those vaccines need to occur in the middle of the work week. So those are all things that are important to do, and all will be very much in alignment with what President Biden announced today.
Thank you. And we do have a hard stop at 1:30, so we have only enough time for a few more questions, and we'll continue with Charlie Robeski from Fox 11 in Green Bay. Charlie?
Hello, thank you for taking my question. Obviously, we know those PCR tests are the gold standard, but do you think at-home COVID tests will evolve? Will they become just our everyday lives?
Happy to throw that to Dr. Westergaard.
Yeah, I guess as I was saying before, I think there's a lot of advantages of using the infrastructure that we have for laboratory-based tests, and I foresee that those will continue to be the mainstay of our testing approach, because the benefits are the results of laboratory-based tests are more accurate. We can trust the result a lot more. We're not going to miss cases by tests being falsely negative or falsely positive and steering us in the wrong direction. And they're directly linked to our public health databases. So there's for good reason that we've invested so many resources into having this testing system connected to our public health surveillance. And I think that'll continue to be the mainstay of our testing. But at-home tests provide another option for people and at times that clinic-based or laboratory-based tests aren't available. And I think that's a good thing. If people have a concern because they had an exposure, they have new symptoms, and it's not easy for them to get to a healthcare provider, a place where they can get a laboratory test, it adds another layer of information. So I think they will be useful in the future, but I think it's important for people to understand that they're not going to replace laboratory-based tests. In many instances, we recommend that we confirm the results of at-home tests or any rapid point-of-care tests with a laboratory-based PCR test to make sure that we're making the right decisions. So will be more guidance about this, I foresee, coming as they become more available and become more accessible or free during the course of the president's plan. But I think our job in medicine and public health is to educate people about what results mean, what to do with them. And I don't think that we'll get to a point where we rely mostly on at-home tests. I think they're just going to be an added resource that we can benefit from.
Thank you. And our final question today belongs to Hannah Borkert from WSAW in Wausau. Hannah. WSAW in Wausau.
Hi, thank you. Hi, thanks. A lot of our viewers are having a hard time getting COVID tests quickly, especially those rapid tests. Is that something we're seeing statewide, and why might it be more challenging to get tested quickly now?
So I think part of what people may be experiencing is there is certainly fluctuation in the supply chain as it relates to COVID tests, as well as other kinds of things. And if by getting tested quickly, you mean finding one of those over-the-counter at-home tests in a pharmacy, for example, I know that the supply does ebb and flow a bit. A couple things to mention would be through the Department of Health Services, we do offer at-home tests that people can order and have sent to them so that they have them on hand for just the circumstance that Dr. Westergaard was mentioning in terms of people feeling symptomatic or knowing that they've been exposed. And we certainly encourage people to look into that. Those are free. And then I also think that, again, really relying on both the information available on the Department of Health Services website, as well as checking with pharmacies about their PCR testing that may be available, again, often by appointment, sometimes via walk-in. And we are continuing to work closely every day, every week with our local public health partners in particular to make sure that we hear about additional needs for additional testing capacity so that we can meet those with National Guard resources if needed or identify other strategies. And before we wrap up, Jennifer, I think Dr. Rai maybe wanted to add a comment on the testing question, Dr. Rai, or are you all set?
Yeah, and just to dovetail on both comments that have been made, it's important to understand what also happens when, say, for example, you come to a clinic for a PCR test, and we're lucky enough to be part of the state pilot where our testing is actually done in partnership with the state and it's covered by the state, so you're not charged for it. But recently, we're able to start running all of those test results, those PCR results, locally in our own lab. And what that means is our turnaround time for a result is much less than a day, sometimes less than 12 hours. But what happens when we know you're positive, I think, is what is really important. For example, at our organization, when we know you're positive, we look at it's looked at every day. Patients are risk scored. And if you're a high-risk patient that's positive, we want to get you in for treatment right away. So you get an automatic call to come on in and to assess if you're ready for monoclonal antibody, and then we make your appointment to get it. So if there was a home test that was done, which have obviously the roles Dr. Westergaard appointed, some of those steps won't happen, and there's a delay. So it's really important to understand some of the advantages we have, thanks to what the state's invested into our local lab resources and partnerships with healthcare providers, and then what we can do with that result to get people in faster for treatments that could prevent a hospitalization. The biggest one obviously being monoclonal antibody.
Thank you. And that does conclude today's briefing. Reporters who didn't get to ask a question, feel free to contact DHS Media and we'll take care of you that way. Our thanks to Secretary-Designee Timberlake, Dr. Ryan Westergaard, and Dr. Ashok Rai, and thanks to all of you for joining us. Please continue to monitor the DHS website for data and guidance and the latest information on COVID-19. Be safe and have a good afternoon.